I want to thank the organizing committee for having me here to talk about this important topic. So, can I have the slide? So, I will be speaking about the molecular genetics of homozygous FH. I will try to cover this outline in the coming 20 minutes, and I will be focusing mainly on the molecular basis and genetic forms of familial hypercholesterolemia. So to start with, as mentioned in the previous presentation, cardiovascular disease is the leading cause of death worldwide, and in Saudi Arabia, as we see here from these data, ischemic heart disease is in the top of the list of causes of death and morbidity among Saudi population. Familial hypercholesterolemia is a genetic condition that predisposes individual to premature cardiovascular disease due to very lifelong exposure to elevated LDL cholesterol. So there is up to 20-fold increased risk for premature cardiovascular disease among these people. And if we looked at those with heterozygous FH, if they are untreated, 50% of men by age of 50 and 30% of women by age of 60 will have cardiovascular event. Moreover, in more severe form of the disease, homozygous FH, this risk will be extremely high, and those people can have cardiovascular event as early as during childhood. To illustrate this further, we can see in the table from this study, Young MI registry, which included around 2,000 individuals with the median age of 45, the prevalence of familial hypercholesterolemia is 1 out of 10 young individuals with MI. And this will increase to up to 6 out of 10 young individuals with premature coronary artery disease, plus family history of premature cardiovascular event and LDL more than 160. So we can see how much this disease is prevalent among people with premature cardiovascular disease. Despite all of the risk and numbers mentioned, this condition is remain largely underdiagnosed and undertreated due to many factors, including poor awareness, lack of national screening program, and limited access to genetic testing, as well as barrier to the newer treatment and as well as to lipoprotein apheresis unit. We are glad to see some initiative from Ministry of Health to address some of these factors. So just brief review about the historical review about the genetic of familial hypercholesterolemia, starting from 1964 with identification of the disease as autosomal dominant by Kashadorian in a Lebanese family, toward identification of LDL receptor and describing the disease as LDL receptor defect by Brown and Goldstein in 1976, and moving forward with identification of ApoB as a second gene that lead to familial hypercholesterolemia in 1985, and toward early 2000 with identification of the third gene that can lead to familial hypercholesterolemia, which is PCSK9 gain of function mutation. Around the same time, as we can see in early 2000, identification of another gene, LDL receptor adapter protein 1, which can lead to autosomal recessive hypercholesterolemia, until early 2010 with introduction of next generation sequencing, which advanced the field of genetic and understanding of the genetic in familial hypercholesterolemia. We have few mutations in ApoE in 2013 that could explain the familial hypercholesterolemia, and the introduction of the new term polygenic in those who have no identified mutation as the cause of the disease. So we can see how complex the genetics of familial hypercholesterolemia became compared to the like early 1980. So starting with the normal process of LDL clearance, we can see here that with the LDL cholesterol and ApoB as a ligand, it will bind to the LDL receptor and it will internalize to the hepatocyte, and then it will be guided for degradation. And majority of LDL receptor will be recycled to the surface. However, part of LDL receptor will be degraded with the presence of PCSK9. Any defect in this process will result in familial hypercholesterolemia. So the most common mutation that results in familial hypercholesterolemia is a mutation and defect in LDL receptor gene. And when we have defective LDL receptor, there will be impaired binding of LDL cholesterol to the receptor and hence accumulation of LDL cholesterol. There are many classes of the mutation and defect that can happen in LDL, starting from the class 1, which is null allele, and will be lack of the synthesis of the receptor, toward impairment in the transport of the LDL receptor gene toward the Golgi apparatus, or when we have defect in the binding between LDL cholesterol and LDL receptor. This is the third one. And the fourth one, when we have defect in the internalization of LDL receptor, LDL cholesterol complex in the clathrin-coated pit. And the last one, the impairment of the recycling of the LDL receptor to the surface. So any defect in this process will result in familial hypercholesterolemia. In the left side of the slide, we can see how complex the structure of the LDL receptor protein. We have 5 major domain with 2 numerous amino acid and 18 exon. That's why we have now more than 3,000 pathogenic mutation identified so far that can result in familial hypercholesterolemia. The second most common one is a defect in ApoB. As we said, ApoB work as a ligand for LDL cholesterol to bind to the LDL receptor. So when we have dysfunctional ApoB, we will have impairment in the binding of the LDL cholesterol to the receptor and hence accumulation of the LDL cholesterol. The third most common, which is PCSK9 gain of function. As we said, when we have a hyperfunction PCSK9, this will lead to increase the degradation of LDL receptor and will limit the availability of LDL receptor that will be recycled to the hepatocyte surface and eventually accumulation of LDL cholesterol. So these are the 3 most common mutations that can result in autosomal dominant familial hypercholesterolemia. The fourth major defect, which is an LDL receptor adapter protein mutation, which is important for the internalization of the LDL receptor to the hepatocyte. So the defect in this protein will result in another form of HoFH, which is autosomal recessive familial hypercholesterolemia. So the inheritance of this disease is autosomal semi-dominant. We have 2 major forms, either monoallelic or biallelic. As we see in the left side of the slide, the heterozygous FH, when the patient inherits only 1 mutant allele from the parent, and the prevalence already discussed in the previous presentation, and in average we will have LDL in the range of 5 to 10 millimole. On the other hand, we have the more severe form of the disease, homozygous FH. When the patient inherits 2 mutant allele, 1 from each parent, we will have more severe disease with LDL up to 10-fold increase in the LDL. Typically, we see LDL more than 10 millimole, and the prevalence is estimated to be around 1 in 160,000 to 1 in 360,000, which is higher than previously thought. The previous estimation was 1 in 1 million, but now we understand this condition is prevalent among population. We have great genetic diversity of the condition ranging from heterozygous to homozygous, or double heterozygous or compound heterozygous, and there are newer terminology suggested by the recent consensus statement of European Atherosclerosis Society on homozygous FH. And we can start with, we have 2 major forms. Biallelic semi-dominant hypercholesterolemia, monogenic, meaning that single gene defect, and the second form will be digenic. And we can divide it further by the causative gene or by the nature of the variant. So as we said, LDL receptor related is the most common and explain almost 90% of the cases. The second most common is ApoB related, and the third one is PCSK9 related. And as we see in the graph, so we can have either 2 identical mutation, we call it true homozygous FH, or different mutation, which is called compound heterozygous FH. The second form, the digenic form, when we have 2 gene defect at the same time, and the most common form in this category is LDL receptor plus ApoB related, and the second one is LDL plus PCSK9 or ApoB plus PCSK9. And this is formally called double heterozygous FH. As we see in the graph, we can have two different gene defects at the same time. The third one, which is autosomal recessive familial hypercholesterolemia, which is due to defect in the LDL receptor adapter protein 1. As we see in the graph, the parent, they are in the carrier state. So they carry the pathogenic mutation, but they don't exhibit any manifestation of the disease. However, there is a 50% chance of transmitting the pathogenic variant to their kid as a carrier state, and 25% chance of having affected child who will express the manifestation of severe hypercholesterolemia. So we can see from this graph that there is wide spectrum of the clinical phenotype of familial hypercholesterolemia with some overlap about this clinical phenotype. However, generally speaking, the phenotypic spectrum of familial hypercholesterolemia depend in part largely on the severity of genetic defect, as we see starting from polygenic form and going up to the more severe form of the disease, homozygous LDL null, in which we will have less than 2% of the functional activity of the LDL receptor. We see extreme elevation in the LDL level. Parallel to this, the higher the LDL level, the more severe the genetic defect, we will have higher cardiovascular risk. On the other hand, we can have also other modifier factor like genetic background. So let us say a patient with heterozygous or homozygous FH, in addition, he have elevated lipoprotein little a. This will increase the risk further. Or if he have high polygenic risk score, this will modify the risk further. Again, if he have, in addition to the pathogenic variant of FH, like protective mutation, like PCSK9 loss of function mutation, this will reduce the level of LDL as well as cardiovascular risk. So in this graph, just to show the idea of difference between monogenic, the more severe form of hypercholesterolemia, compared to the polygenic, which is prevalent among general population. And the idea behind polygenic, when we have multiple small effect allele of single nucleotide polymorphism altogether, it can result in the effect on the LDL as well as cardiovascular risk. This is a graphical representation of the common reported mutation in LDL receptor gene from Saudi Arabia. And this is a summary of 6 studies reported from Saudi Arabia about LDL receptor variation. And I want to drag your attention to this specific frame shift mutation in exon 14, which is reported from different unrelated Saudi families from different areas of Saudi Arabia. And this could be the founder FH mutation in Saudi Arabia, and this could indicate the high prevalence with the presence of this founder effect, which is amplified by high rate of consanguinity rate in our area. So what is the rationale of doing genetic testing? So it provides us with a definitive diagnosis, also improve the risk stratification and prognostication, and also it is very important for cascade screening, prenatal genetic counseling, as well as it has been shown that knowing the genetic defect improves the adherence to medication, and also it can help to exclude other mimicker of the conditions. So in this very nice study, they compare people with hypercholesterolemia who have pathogenic variant in red color, or those who don't have pathogenic variant in blue color, with regard to the odd ratio for cardiovascular disease. So we can see in those in the range of familial hypercholesterolemia with LDL more than 5, we can see almost 3 to 3.5-fold increase in the odd ratio for coronary artery disease in people with pathogenic variant compared to those people who don't have familial hypercholesterolemia mutation. More interestingly, across all categories of LDL level, we can see that the presence of pathogenic variant and genetic defect provide us with further risk stratification information, as we see that across all categories, people who have pathogenic variant have higher odd ratio for cardiovascular event. This is just suggested approach for a patient with familial hypercholesterolemia. As discussed earlier, we will exclude secondary causes first, and then we can do targeted genetic testing. If it is positive, we'll proceed accordingly. But if it is negative, we need to think about other causes like polygenic hypercholesterolemia, extreme elevation of lipoprotein little a, ApoE, or other phenocopies of the condition like cytosterolemia or lysosomal acid lipase deficiency. This approach is specific for homozygous FH when we have LDL more than 10. We need to exclude secondary causes, and we can do targeted next generation sequencing. If we found a mutation, this is homozygous familial hypercholesterolemia. If it is negative, then we need to look for other mimicker like cytosterolemia or LAL deficiency. So cytosterolemia, or also called phytosterolemia, so it is autosomal recessive disorder due to pathogenic mutation ABCG5, ABCG8. So normally, the cholesterol and the blantosterol will enter to the enterocyte through Niemann-Pick-C1 like 1, and more than 95% of blantosterol will be pumped out through this transporter, ABCG5, ABCG8. However, when we have defect in this transporter, there will be accumulation of blantosterol in the tissue with the result of the manifestation of severe hypercholesterolemia, accelerated atherosclerosis, and increased cardiovascular risk. We can show the level biochemically, however, it is not widely available. That's why the role of genetic testing. And it is suspected clinically when the statin, when the patient have like suboptimal response to statin. On the other hand, they respond very well to ezetimibe or bile acid sequestrant. This is a recent case report of typical cytosterolemia from Saudi Arabia. The last slide about lysosomal acid lipase deficiency, which is the second phenocopy of the disease. When we have mutation in LIPA gene responsible for lysosomal acid lipase, we'll have almost complete or partial deficiency of the enzyme. It has wide range of the manifestation ranging from fatty liver disease to liver cirrhosis, elevated LDL, and accelerated atherosclerosis. And the treatment is with CB lipase alpha, which is a human recombinant lysosomal acid lipase. In conclusion, homozygous FH is a major risk factor for cardiovascular disease. However, it remains underdiagnosed and undertreated. Molecular genetic research improve our understanding in this disease, and we understand now it is more common and more complex than previously thought. The severity of phenotype of FH depends largely on the severity of genetic defect, and assessing the underlying genetic defect increase the risk stratification and also improve in selection the appropriate therapy as well as the adherence to treatment. Despite all of this benefit, genetic testing remain underutilized in the clinical practice. And thank you.